Okay, good morning, good afternoon, and good evening to everybody all around the world. Thank you so much for joining us today. Our session will now begin. Next slide, please. This is our confidentiality disclaimer. The content in this webinar is intended for educational purposes only. Individuals who have access to this webinar with case reports and patient information shall not distribute the content without prior consent from LIGHTMED Corporation. Thank you so much. Next slide, please. So please note that your microphone will be muted during the presentation. We'll have question and answer session at the very end. Next slide, please. And if you are new to the platform or not familiar with the functionalities, this is how you will ask a question. If you're on your mobile device, on the left side, you will see this is what the control panel looks like. And on the bottom, you'll see a question button. You can click that button and type your message into the enter message section and click send, and we'll get to those questions in the very end. If you're on a PC, the control panel will look like the middle section here, and you will also be able to click questions, type your question, and click send. If you do not wish or do not get to your question during this presentation, feel free to send questions to us at any time at sales@lightmed.com. Thank you. Next slide, please. Okay, and now the session will begin. Thank you again for joining us today. Next slide, please. And it's my pleasure to introduce Dr. Miguel Rechichi from Italy for combined laser therapy for treatment of retina diseases. And again, thank you so much for joining us.
Thank you, Jennifer, and thank you to the LIGHTMED and all the audience for being here in this hot, sunny, at least in Italy. So my name is Miguel Rechichi. I come from south of Italy. I completed my training just around the world between Italy, US, India, and also UK. And actually, I'm the founder and the responsible of the Centro Polispecialistico Mediterraneo, which is a large clinic in which ophthalmology is the main thing. My experience with the laser is focused also on cross-linking protocols. I developed a lot of protocols in the laser for cross-linking, but today I will speak about my experience with this beautiful LIGHTMED TruScan Pro yellow laser. So, what my first impression about this laser? Is really stylish, and as Italian, I really enjoy it. It is very compact and fit well in my clinic. It is really mobile, and you can also use in the vitreoretinal surgery with the right option, connecting the fiber directly to the laser. And why I choose this laser for my clinic? It's the same reason why I choose Tesla Model S as a car, because you can really do a lot of things with just one laser. So with my car, I can go fast. I can have the space of a cargo, and I can go also off-road. And for the same things, I really enjoyed this laser because with one laser fits for all. So you can do brilliantly the conventional pan-retinal photocoagulation. You can choose different spot, different pattern. Is very easy to maneuver. And I really enjoy the technology of SP microsecond laser for treatment of macular diseases. So really, I am very, very happy with this laser. So let's introduce what is a yellow laser. What are the benefits of a yellow laser? Now I think it is the best option if you want to buy a laser, because the 577 yellow laser light has a peak of absorption for the oxyhemoglobin. So it's perfect for vascular lesion, for example, for photocoagulation in diabetic retinopathy. Is a low intraocular light scattering, less pain for the patient, and it's not absorbed by xanthophyll, so it's very safe also if you use in the macula. So you can use it also in a moderate to medium cataract patient, because it's the light really is really focused also in these difficult patients. And you can use it for treating abnormal vasculature, and the patient really does not feel the same pain of other wavelengths. So, as I mentioned before, you can really use for a wide range of retinal diseases like diabetic retinopathy, central branch retinal vein occlusion, and you can use it for fixing retinal tears, holes, or partial retinal detachments. But you can also use for endophotocoagulation if you connect to the surgery light fiber. And what about the SP-Mode? That to me is really what is wonderful for me, is that you can treat with a great safety and efficacy the diabetic macular edema and other macular disease like central serous chorioretinopathy. You can also use for glaucoma as an advance to do laser trabeculoplasty, and with the SP-Mode you can also use in glaucoma and repeat the treatment because you will not have any scar in the trabecular meshwork. The beauty of this laser is that you can easily choose a lot of patterns. You can do just simple single spot. You can perform in a square way. You can do photocoagulation with a circle, triangle. You can angle any ones you see, and you can also store each of your favorite patterns in the machine. So you just do one click, and the next time you will have your preferred pattern, your preferred energy, and your preferred parameters. So what is SP microsecond mode in this laser? I think to me that it is a revolution, like was a revolution the pulsed mode in our phaco machine for cataract. So the beauty of the SP mode is that the laser will not really burn, will not cause any scar into the retina and in a photoreceptor, because the rise of temperature is mild, because the energy of the spot is reduced by 5%, of 10% or 20%. You can choose. So you will not reach a rise in the temperature that will burn the retina. So you will have just a mild increase of 10 to 15 degrees in temperature respect to the conventional body, and you will not see any visible scar or burn in the retina. So you can treat easy also directly the fovea. I will show you now an animation about the SP-Mode, in which you can understand better with this beautiful animation the role of SP-Mode in the laser.
There are two types of laser irradiation: continuous wave and SP-Mode Microsecond Laser Technology, which uses short sub-threshold laser pulses that treat the eye without inducing pain or causing visible laser burns. SP-Mode's energy pulses are separated by short rest periods, during which the tissue has a chance to cool down before the next laser pulse. In SP-Mode, the time on is the duration of time that the laser is turned on. The time off is the interval between successive on periods, which gives the retina the relaxation time and allows for cooling. This regulates the additive effect of each pulse of laser power and ensures minimal collateral damage to the tissue. The ratio of irradiation time during one cycle is called the duty cycle. One cycle is 1/500th of a second, or 2 milliseconds, which equals 2,000 microseconds. When the duty cycle is set to 10%, irradiation is on for 200 microseconds out of every 2,000 microseconds, and it is off for 1,800 microseconds, whereas changing the duty cycles would vary the time that irradiation is on and off. The duty cycle and power are adjusted to provide the required level of energy to be applied to the target cells. The laser invasion level depends on the amount of energy measured by joules. With conventional continuous wave laser, white flecks are formed where you can see a visible burn mark on the retina from thermal coagulation of the retina cells. This level is called the threshold, which is the minimum energy level where you see the white flecks. If irradiation is performed at a lower energy level or subthreshold using SP-Mode Microsecond Laser Technology, scarring does not occur and you get a therapeutic effect. When the energy is reduced below this subthreshold level, there is no therapeutic effect. SP-Mode treatment is selective and targets only the retinal epithelium, also known as RPE, ensuring that temperature elevation is confined only to this area and sparing the neurosensory retina. SP-Mode treatment leaves no visible marks and maintains the safety of the retina due to the low energy pulses. Ongoing clinical studies and publications demonstrate the SP-Mode Microsecond Laser Technology as a very safe and effective treatment. It has also been shown to be highly effective in treating the retina and glaucoma and comes standard in all LIGHTMED photocoagulators.
Okay, so now I think everybody have an idea of what is the subthreshold therapy in and the SP mode. Now I wrote three of the, I think the the most important question about the using of this modality. So the first question is how I titrate the energy. This is usually what I did, especially in my early cases. I will point the laser in the non-edematous area in the vascular arcade, because here the thickness of the retina is quite similar to the fovea. But I'm putting my my 3 disc diameters away from the foveal center. I put a 200 micron spot with a duration of 200 milliseconds and the power of 15 milliwatt. And then I slowly raise the energy until I see just very visible tissue reaction. So just a little whitening of the retina. And then after this, I then switched to initially to the 5% duty cycle after adjusting the power 4 times the test spot. For example, if the test spot is a 60 milliwatt, I will do 6 for 4, and I will shoot with a 240 milliwatt of energy. I always use 4 grids, sometimes more, depends also on the pathology. The grids are made of 7 for 7 spots, and a confluence spot with a diameter of 200 micron. Zero spacing because I want to cover the edematous area, and I include also the foveal center. So usually I start with a 5% of duty cycle that actually to me was very effective with these parameters, and sometimes I rise to 10%. To date, I do not need to go further for duty cycle, but most of my effective cases are I did with a 5% of duty cycle. And what about the best energy to use for other retinal treatment, conventional treatment? I normally, in a clear eyes with no cataract, I have a good photocoagulation effect at 270, 300 milliwatt, 0.2 second of exposure, and 200 micron of diameter. So this fit for most of my cases. And what about cases? I will show some cases that to me was very, very important, and they gave me also the perception of the goodness of the laser. And I will show the cases that really feared me because this patient is a very young male, 41 years old. The vision is in the left eye was counting finger because he had an epitheliopathy and central serous retinopathy in 2012. At that time, there was the anti-VEGF treatment was not so diffused, so he was treated with a PDT, and finally he developed a macular atrophy. So the vision actually was counting finger in the left eye, but unfortunately he presented to me with another central serous chorioretinopathy that was treated elsewhere with the drugs because the colleague was really feared about doing anything more than medical therapy. So it was treated with a combination of acetazolamide, eye drop of nepafenax or other fans, dexamethasone eye drops, and he had no results. For sure, the feared about using any kind of laser in the right eye because of the results in the fellow eye. So I was a little bit scared about also treating this patient that was functional focal. So I performed the angiography and ICG, and the situation was this. I a focal leakage point that was outside the macular area, and I had some leakage here in the near the foveal vascular zone. So this is the autofluorescence, and what I did is my choice was to treat with a focal laser treatment this point with the parameter of 100 micron diameter of the spot, 0.1 second of exposure, and the power of 180 milliwatt. And what about the macular area? I treated with SP-Mode 7.7 grid, with a 4 grid that will cover the entire macular area, and the power was 310, 100 micron the spot, 200 milliseconds the exposure, and a duty cycle of 5%. So this is the shoot for the laser parameters. This is the representation of the on the covering of the laser. Okay, so I will do focal laser here and subthreshold treatment here, and as you can see in the autofluorescence after the treatment, you can see the visible scar here in the leakage point, but you can see any visible scar in the foveal area. So this is the proof that really the subthreshold treatment didn't provide any scar in the macular area. And this is the results. So after the treatment, the retina the liquid, the subretinal fluid start to reabsorb, and after 3 months, it was completely solved. This is another shoot for the progression. And the good things is that I have really an immediate result, because if you see, I have a result in just 2 months, and the patient was really happy because he's recovered 810 vision, and as you can see, no visible scar on autofluorescence in the macular area, and a visible scar in the leakage point. So my idea of applying the SP mode is to cover the full macular area, reaching up more than 500 spots, and this really improve also the epithelial pump, and improve also the absorption on the fluid. So with the focal laser, I act on the production of the retinal fluid, and with SP mode, I act for promoting the fluid reabsorption for the epithelial pump. This is another cases of a persistent irvine gas syndrome. This was a very myopic patient in which I had an eventful phaco surgery in right eye, and in the left eye he developed an irvine gas syndrome just after 1 month. And I treated in the first phases with a combination of acetazolamide, steroid drops. I have a success because here this is the treatment with This is the image before the treatment and after just 2 months. You can see this is October and this is December. So I have a complete resolution of the subretinal fluid that is lasting until now, and now it's 8 months of follow-up. So this is the curve after SP-Mode treatment, and it was really, really effective. This is another cases of persistent macular edema after branch vein retinal occlusion. The patient was treated in the first episode with the 2 intravitreal injection of triamcinolone, and it was quite stable and for months. Then he started to reaccumulate some subretinal fluid, and at this point I decided to go with a SP mode instead of in intravitreal injection. And then after 2 months I have another very big resolution of a subretinal fluid, and also this since now is very good, so the result is consistent and also durable, because I have now 6 months of follow-up and nothing happened. And I will show you now also real-life treatment for a retinal peripheric retinal hole, in which you can see how you can change the pattern of the laser during the treatment. This is a circle pattern. Then I switch rapidly to the square mode, square pattern, and easily cover the large retinal hole. You said that I told you never. Okay. It's easy and really very, very fast. So this is the treatment immediately after the laser, and it just takes less than 5 minutes, and a beautiful and consistent results. What actually we are trying to do? Actually, we are trying to use the SP mode also for treatment of drusen, and then for prevention of dry and wet AMD, because there is some scientific evidence, as long as the people said about the nanosecond. But I think that SP mode with the right titration could activate also reactivate the epithelial pump, and could be useful also for the treatment of the drusen. But actually we're now collecting some cases. We are starting to have some beautiful results, and I hope we will show you the first data in the next year. So thank you for your attention, and I think that we can open the question and answer session for this. So thank you for your attention.
Thank you, Dr. Rechichi. That was really, really nice presentation. You found some great cases, complicated cases, and introduced very well all of the settings that you've used with some good results. So thank you so much for sharing that. We have some very general questions if you can help answer. First of all, someone is asking, which layer does the yellow laser burn?
Yeah, the the yellow laser really acts on the epithelial pigment, RPE, but depends on also on the energy, because it's always a question of a titration. So the yellow laser has a peak absorption that is not for xanthophyll. So really do not make any burn in the, if you use conventional power in the photoreceptor layer. So for this reason is more safe respect to other laser with other wavelengths. That's the reason why the yellow laser is always the best option for safety.
So if I'm used to using the green laser, for example, do you think the SP mode is just as effective with the green laser?
No, I think that you can do titration and SP mode also in other wavelengths, but I think that the combination with a yellow is the best combination, because you have the two reasons of safety. So the yellow laser and the SP mode. So the green laser, you can use it. You can use it also for photocoagulation, but usually the patient feel more pain, and honestly, I will not do in the macular area. I will not do this with a confidence in the macular area. With a yellow laser, really, after the fear of the first patient, now I treat regularly in the foveal zone. And if you use the starting parameter that I showed to you, you will never have any problem of a foveal damage.
Okay, perfect. So let's see. How do you decide which duty cycle to use? Because you said you use usually 5%, is that correct? Do you change any time, and why?
Okay, if you look at my presentation, I just took a shoot of my parameters that actually I use for more than 90% of cases. And to me, it was very effective. So my advice is to start always with a 5% duty cycle. And then if you do not experience any improvement, you can do a second session with a 10% of duty cycle. Because the problem of subthreshold treatment is that you can see immediately the result. Sometimes you just wait 1 month, 2 months. Sometimes you just wait more than 3-4 months. But if you do not have any fluid reabsorption after 2 months, I think the treatment is too light, and we have to switch versus 10% of duty cycle.
Okay. Can you go to your first case, please? I think
Yes.
it's slide 19, or maybe before this. I have a question for this one.
This one, the first
for the
case,
first
is this is
see.
the central serous retinopathy in the monocle patient.
Okay, so I have a question. Do you always irradiate with SP mode in the fovea area in the case of CSC, even though the leaking point is clearly seen, like in this case?
Yes. As I also explained before, in the central retinopathy, there is two problems. There is a leakage point who will refill always the subretinal spaces if you do not coagulate, And on the other part, there is also a suffering of the epithelial pump. No, for example, why acetazolamide is a good medical drug, because it also not only acts on the reabsorption, but it also promotes the epithelial pump. And the effect of a SP mode in the, like in these cases, is also to reactivate the epithelial pump. More than this, in these cases, if you look at the angiography, you also have a tiny leakage point there, you can see. So I, in these cases, treat also the foveal area, and also I treat this because this is the most close leakage point to the foveal area. So the big one is this, but there is another one here. And if you do not promote the epithelial pump there, you probably you will not have the same speed of recovery in subretinal fluid. So I always advise to do both. The only way in which I do not recommend to use a sub SP mode is when you have a macula, a foveal area in which the thickness is more than 400 micron of thickness, because in this way probably the retina is like a sponge, and the laser will not be well absorbed by the retinal layer and the APR.
Okay, as a follow-up, did you compare the results between the treatments, like for example, only at the leakage point compared to combined with the diffuse irradiation at the fovea?
For sure, I cannot do. I do not have data with the same laser. I have retrospective data with my previous laser that was a conventional yellow laser without SP mode, and it's my impression that I have also a good result with the laser, but the speed of reabsorption was lower. It took about 3 or 4 months. But if we have also to be very honest in these cases of a central serous retinopathy, telling that each case is different. It is not like cataract that 90% of cataract look like the same. Each case of central serous retinopathy is slightly different. Sometimes you have a leakage point that is big and very far from the fovea. Sometimes you have epitheliopathy with multiple leakage points. So I think that real comparison is not so possible. And also in the literature, sometimes they compare singles versus combined treatment, but to me, is not so reproducible as a scientific study. So in these cases, you have to follow the results. My impression is that combined treatment speed up the fluid reabsorption.
So you mentioned in some of your cases that you had some immediate results within 2 months. Is this pretty standard for 2 months, or would you recommend something different for your follow-up time?
No, I just show you the 2 months follow-up just to underline the good things and the speed of the recovery. But in these cases, the real follow-up, that's the way why I show you also the long term, the mid-term data. You have to wait at least 6 to 8 months to say that the case is really solved. And you have also to see an angiography after this, after 6 or 8 months, to confirm that the leakage point is definitely closed.
Mhm. And if you don't get those results, I mean, after 8 months, do you recommend to retreat?
No, I'm not a fan of retreatment after medium of if the follow-up in the medium is good, because in my opinion, you have to treat just if you see some little evidence of recurrence. I do the same with the IVT treatment. I usually perform a free intravitreal injection, and then I just perform another injection if I see some liquid, and I apply the same criteria for the laser. If I not see well, why I have to treat?
Mhm. Okay. How long do the results usually last?
Okay, it really depends case for cases, but if you have retinopathy with just one leakage point, if you do not have any other leakage point, it usually lasts forever. The problem for central serous epitheliopathy is that sometimes by the time a patient develop any other leakage point, that's the reason why you have to follow up with a angio OCT or angiography at least 6 months, or if the results are always good, each year. But in the first 3 years, I usually perform at least an angio OCT every 5 or 6 months.
Okay. We have another question. It's about the laser. Have you or any of your colleagues used the yellow wavelength SP mode for glaucoma treatment?
Okay, actually, I didn't speak about this because I'm starting my own experience. I just treated 8 cases, and actually I have a good results with an average lowering of IOP of 8 millimeters of mercury. But actually I am very adherent to reality, so I didn't show you the data because I want to have a consistent and at least 6 months of follow-up. I spoke with colleagues that have better experience respect to me in glaucoma, and they are very happy. But you know, I like to speak about what I really can show you. So actually, my experience on glaucoma treatment is limited, but I think that the rationale is all there. So I think there is a good starting point also for treating glaucoma patients.
That's good to hear. Do you think that it will be comparable to SLT? I mean, according to your colleagues, maybe that what you've heard.
For SLT, I have a very good experience with really a lot of cases, and I actually am very happy with the SLT. The results with a few cases that I do with SP-Mode are quite comparable, and also the limits are comparable. So the same patient in which SLT will not work is the same patient in which also SP-Mode will not work. So in my little experience with SP-Mode, I should say that is quite comparable.
Okay. Would you be willing to share what parameters you use for your glaucoma treatment?
Yes, I didn't have here my parameters, but Usually, I use a spot, a very tiny spot, 50 micron. I use a duty cycle of a 5%, and usually I titrate the treatment starting for 300 milliwatt with a 5% duty cycle, and sometimes you can see just a little bubble. So when I see a little bubble is too much, and I go lowering the energy. But actually, I'm trying different kind of energy. So actually, I will not have my favorite protocol since now, because I need to acquire more data, because gives you real good parameters.
Okay, perfect. Thank you so much. I think we are almost done with questions. I'm just going to leave a couple minutes if anybody else has any questions in the meantime. Can you tell the audience, will you be presenting a presentation at the Academy this year? And we will expect to see something from you?
Yes, I think I will show you some other data in the next academy. We probably will I will involve with the with the LIGHTMED also for some booth presentation. And to me, I think that the best experience is to tell face by face into the booth, more than showing also the data, because sometimes it's the curbside consultation that is the best way to improve our experience in with this laser. What I want to tell is that really I was really excited to use this laser, because actually to me it's like the Swiss knife. I discover every day a new way for treatment and a new way in which I can use this laser. So really I was very happy, because sometimes I bought two or three laser for doing just one or two things, and actually I'm using it for really a wide variety of eye pathologies. So really excited.
Well, thank you, Dr. Rechichi. It was really nice to hear that you're using it for all sorts of things. We're very interested to hear about your results and findings with the future of drusen and AMD, also your applications for laser trabeculoplasty.
Yes.
It looks like I have one more question here. What is the rationale for your titration method with SP-Mode?
The rationale for titration in SP-Mode is not to be too much aggressive. You know, the first time that you shoot the fovea, you will be in some way really feared, because since now is natural to put the laser directly on the fovea. So I think the first thing in all the new things that we do in laser in surgery is the safety. So to me, titration is fundamental. But what I want to tell you, that after my first experience, I now I use the parameters that you saw in my slides for 90% of the patients. So I think that in the future, if I will collect data with the other colleagues, I think that we can put also in the laser the basic safest treatment, in which any colleagues could perform with absolutely safety treatment on the macula. Then everyone could also change, everyone could raise the energy, but the first thing is to titrate well the laser is the safety, because remember you are going to put your laser in the most important zone of the retina, the fovea.
Thank you. And you said so yourself, the patients also are very happy and that they don't experience pain.
The first patient that was monocle is actually one of my best market spot for laser. And really, when you are going to perform a laser in a monocle, you take a great responsibility. What is very important also for the patient, it is sometimes you have, for example, a diabetic patient that did 10, 12, 20 intravitreal injection, and if you combine with the SP mode, you sometimes reduce, sometimes you eliminate the need for further intravitreal injection. The patient is always feared by the surgery, but the patient is always very, very, very good if you propose just the laser. So I think that we have to think at the best treatment. We have to think at the less invasive treatment, and the patient is always will always choose the less invasive treatment. So also, if you want to grow the activity in your just in your office and not in your filter, I think that the use of this kind of laser is mandatory.
Thank you. Can you go back to your slide, Dr. Rechichi, just to finish here with the titration steps that you have in the beginning
Yes.
of the cases?
Yes.
Especially for those that are new to SP-Mode treatment.
Yes.
Just explain one more time your method.
Okay.
I'll be close.
Okay. I will show you also with the laser pointer, so we can underline the point. So you go inside the vascular arcade. Okay. For example, I always use at least 3 disc diameters long from the far from the retinal area. I will show you a retina so we can understand better what I do. Okay, so for example, I go there here inside the vascular arcade, because here the thickness is close to the thickness of the fovea, and I just set the a spot of 200 micron of diameter, 200 milliseconds, and 50 milliwatt. Okay, and I put a laser. If I do not see any whitening of the retina, I go 10 milliwatt. I raise the power of 10 milliwatt, and then depress the pedal. And I do this until I see just a barely whitening of the tissue, and that's there. Once I reach this energy, the right energy, I multiply for 4. So if I have a whitening at 15 milliwatt, I multiply 50 for 4, and the final power is in these cases 5 for 4 is 200 milliwatt. Okay, and then with 200 milliwatt, I switch to 5% of duty cycle. Sometimes I probably I will build the video so anyone could review this and can use it in the practice. But once you do 1 or 2 times, it's quite easy. It's quite easy, and this really worked to me. I spoke with a lot of my colleagues, and anyone has a little change in this method of titration, but to me, this method for me is very good. But once you do this, I actually perform most of my treatment with exactly these parameters: 310 milliwatt of power, 200 millisecond of exposure, a spot size of 100 micron, and I use transequator lens. So the real spot size is this 144. So remember that the diameter of the spot is calculated really different respect to the lens you use. For this kind of treatment, I use a transequator that has a multiplier of 1.44. Okay, so if you set 100 micron the laser, the real spot is this multiplied for this, and in other words, the final spot is 150 micron at diameter. Okay, and the grid is like this, is a 747 grid. So actually this parameter to me is what I use it in 90% of the cases, except in the cases in which there is a very big foveal edema. In these cases, I will not perform laser on the fovea, but I perform the laser outside the fovea to reactivate also the epithelial pump.
Okay, perfect. Thank you so much. That was the perfect kind of revisit to your methods to close the session today. Thank you so much for everybody that attended. We have the session recorded as well, so I'll be sharing that a little bit later. But it's a pleasure to have you with us today, Dr. Rechichi. Thank you so much for all of the information and your time.
Thank you, and thank you for inviting me. See you. And I hope to see you not only on webinar, but to see you all and all my colleagues by face in the next year.
Thank you so much.
Goodbye.
Bye.